Um, and then we'll be going from there. So when you do log in, just mute yourselves and enjoy the lunch and learn. All right, Dr. Verna.
Hi, everybody. Good to see you guys. We'll go through the MedX, and you know, one of the things that you have to understand, it's just a machine, so don't be intimidated, and it's not going to replace your clinical skills, but I'll give you some pointers and a little bit of a background. We came into MedX, gosh, about 30 years ago, so it kind of dates back. I was probably your age when I got involved with MedX. Dr. Mooney at UCSD, and he already was doing a lot of research with MedX through a gentleman that convinced him to use the MedX was Arthur Jones. And he really showed him that by isolating the lumbar spine and really getting the weak link stable, that low back patients would do better. And sure enough, a lot of the research has proven that. And not only that, I want you to go beyond MedX today, because again, it's just a machine, but really look at high intensity training. But to do high intensity training of the lumbar spine, sometimes you have to make sure it's isolated, because once the pelvis moves, you know, you're going to be activating bigger muscle groups like the glute muscles, and they're going to overpower the multifidus. Have you guys ever seen a surgery where they're removing the multifidus for fusion? And some of the instances are pretty small muscles. They could be that thick, depending on the level. And then look at your glute muscles, which are one of the most powerful muscles in your body. So if you just do strengthening, crate lifting, things like that, that's okay. But if the glutes are really activated, or the flexor muscles or the psoas or other muscles, the weakness in the multifidus remains. So there's a lot of research to support that. So we'll get started on the MedX, and then hopefully we'll have some time for questions. Oh, wait a second, I didn't share the screen. So share screen,
Yep.
Right?
And then share right here.
All right, does everybody see the screen? Can you give me a thumbs up? Yeah. Okay. So one of the things that's really important, not just with MedX, but with really all the patients we see, most of the patients that we see, even though that you think they're a new patient, a lot of them are chronic. You know, the definition of chronic, especially for back pain, for spine patients, typically there's several definitions, but the most accepted definition is anything after 3 months. So if you have 3 months of back pain that goes beyond that, then it's considered chronic pain. And I'd venture to say, if you dig deep on your patients, the majority are chronic patients, and they all have something in common. And when you start asking them, you're going to see that because of pain, they're going to fear activity. And the majority not only fear activity, but they may have been treated incorrectly. Somebody who's not up on guidelines, you know, they may have had excessive medications. You know, narcotics are a big issue right now. And even though there has been some breakthrough and it's identifiable, you're going to still see patients with narcotics. There was a recent study about 2 years ago, or actually 3 years ago, that showed that if you're older and white, there's still a propensity for an urgent care or an emergency room to give you narcotics. But if you're Hispanic, you know, brown color, or if you're African American and you're young, you're not going to get the narcotics. So it even goes into racial barriers. So regardless of that, typically when you have pain, your patient will stop doing some activities, right? And they're laying around. And then as they do less activities, they typically will have more pain. And that's what all the studies show. And then they do less activities. And if you think about it, we all know somebody like this, either a patient or family member, where you could point out that, you know, they've been through and they maybe had a failed surgery and now they're doing less activity. And every year it creates more of a deconditioning syndrome. And so what you're going to see is that diagnosis at this point may or may not matter if you don't have any red flags, because, you know, 3, 4, 5 years later, is it really that herniated disc? Is it really that sprain strain? Probably not. Now you're dealing with inactivity and deconditioning and atrophy of structures in the spine, including muscles including changes in synovial joint, including changes in pH and the different joint structures, chemical changes. And it creates more pain, not less pain, more avoidance, and it's a vicious cycle. Obviously, muscles are important, but again, looking at the bigger research, Dr. Mooney took out samples of, we used to call it disc juice, and look at disc fluids, look at different fluids on the different spinal joints. And there is a difference in pH and makeup when somebody is not using those joint structures. You know, look at it as lubrication for the joint or that engine. And so when you're exercising, you're doing isolating that area, you're not only making changes on the muscles, but you're also making some chemical changes, and also more importantly, psychological changes when the patient can do more things and they're not afraid of the pain. So if we look at the muscles, we're really looking at the deep muscles inside the spine. These are our favorite muscles that we look at. Yes, abdominal muscles, transverse abdominis, all those other muscles are important. But to us, you know, our favorite muscle group are the erector spinae. Why? Because they're closest to the spine. That's where we focus our research. So we have bias there, and we have shown changes. Not to say that other muscles aren't important, but to us, we look at those muscles being secondary or tertiary things. So one of the big things that happens with the MedX is that the immobilization of the pelvis, like I mentioned before. Then there's a counterweight mechanism, and I'll give you 2 cents. And also the ability to work out in an isolated but full range of motion. And then for testing, where we do have the testing machines, it's very safe because it's done isometrically. That's one of the things why the MedX machines have survived. If you look at a lot of the gyms, you notice there aren't any cervical machines. And my knowledge, the reason why that's the fact is that there's been too many lawsuits with people injuring their necks in gyms. So to my knowledge, I haven't seen cervical machines in gyms for a long time. There's still some so-called back extension machines, but they don't isolate the pelvis. So you're really working out your glutes and your hip flexors, which that's what you want to avoid really until the structures are functioning properly, like the multifidus and other erector spinae muscles. Because again, when you have a muscle that's 4 times, 6 times stronger than another muscle, and you're making that muscle stronger, it just continues to deactivate the weak link. So immobilization, now MedX says you have 72 range of motion in the lumbar spine. The AMA says you have 60, and that seated position for the MedX purposes, let's say you have 0 to 72, and that's isolation. So 0 to 72. And this is a restraint mechanism. You know, you have the footboard pushes into the femur restraint, and then it locks onto the pelvic restraint. You can't move that pelvic restraint up and down. You're going to get patients that complain, but you can't put a pillow there. You can't adjust the seat height by putting another pillow underneath if they're too short. And then also explain to the patient, look, you're only going to be there for a short period of time. And yes, it is a bit uncomfortable, but if you explain to them the importance of just what I told you, you're isolating the pelvis, so you're only working out your lower back muscles, and you can push as hard as you want with your legs. And it's important because we're trying to activate muscles that are dormant. And if you tell the patient that, the majority are going to accept that answer, and you can coach them through. I also prepare patients that tell them that they're going to be very sore after the MedX workouts. And I even tell them that they're not going to be able to walk straight after the MedX workout the next day, and they're going to be sore for 2 days. Now, the majority are not, and then they think you're a hero. They're going to say, wow, I felt really good about it. But people who are sore because you are isolating very specifically, they're not going to be afraid. Remember, they're already afraid of working or movement, and now they wake up the next day after you work them out and they're really stiff and painful. So you want to prepare them for that, just like you would for any other exercise that you're doing on a body part that you really isolate or do high intensity training. Okay, so these are the forces. So pretty easy to see on the schematic. Now, the non-computerized machines are a little bit different, but very similar. And this machine was a really cool machine. I got to be on it in Gainesville, Florida. They spent about $2 million on this to develop the counterweight, because one of the things that was very, very important early on was the testing. I still feel the testing is important for the visual feedback and showing things to the patient. But the reality is, remember, low back pain is not highly correlated with strength. So you could have a very strong back and you could still have back pain or a severe episode of back pain the next day. However, back pain is highly correlated to endurance. So actually, when I have patients, I test them isometrically, but I also still do a Bering-Sorensen or an EDO test. Because again, this year, what you're going to be learning is the more information you have on performance, you're going to have a lot better knowledge to develop a very specific and more robust plan of care. It's not going to diminish your clinical skills. You can still do your manual, you can do whatever you typically do. But look, guys, if you don't have enough information, I'm sorry, it's like having a blindfold when you're treating a patient. And we really got to get out of that mindset and start practicing more psychologically informed treatment approaches and putting functional exercises that are going to supersede some of the non-functional. And by the way, sitting down in a MedX machine isn't very functional. So again, you want to start with this, get the weak link strengthened, and then move forward to more functional things. So the counterweight, they spent a lot of time in research. There's about close to 80 studies on MedX. If you want, send me an email. I'd be happy to send you the latest studies, and I can show you some of the studies where they develop things like the counterweight. But essentially, think of the counterweight as putting somebody on an even playing field when you test. Okay. And so when you test at the different angles, and then those angles overlap 6 degrees each way, you can have a torque curve that's developed, which is linear and ascending or linear and descending, depending on how your strength is. And from there, that can give you the strength, and you can compare it to normal males or females. The other things that you have is you have the visual feedback. So the patient can see when they're doing their tests and actually counts the repetitions, and you can look at form and so forth. So if you look at the testing, because it was so accurate, if you tested somebody on day 1, day 2, day 3, look at how close they overlap. Now this was published at University of Gainesville, Florida, but it's extremely accurate. And if you think about it, how do you usually test when you do an exam? We all do manual isometric testing, right? And it's fairly accurate. If you want to be more accurate, you could use a dynamometer to do, for example, biceps strength, tricep strength, or whatever muscle you're testing. But this is very similar, but on the machine that's extremely accurate. You could reproduce the tests from day 1, day 2, day 3. If we look at the curve, it's linear and ascending, from 0 degrees being the weakest because you have less of a fulcrum, and full flexion at 72 when you're bent forward, almost touching your knees to your chest. If you're flexible, you don't have a belly like me, right? I can't touch my chest. Or maybe I can. I don't know. We'll try it. Maybe we'll try it. Anyhow, from there, that's what a normal curve looks like. Now, in an athlete, it's actually the opposite. That's why I said it could be linear ascending or ascending and descending. Because in an athlete, you're going to find they're stronger on extension than flexion typically, particularly a football player, volleyball player, MMI fighter. On the neck strength, you're going to see variations that are way higher on extension, because that's how you don't get knocked out. You have strong erector spine in your neck. So from here, this is a really interesting one, not only for MedX, but really for age. Look at the difference between males of 18 to 35 and males from 36 to 59. There's not that much of a difference in strength, but boy, look at the difference when you hit 60. Look at how much more weakness you have. And by the way, guys, this is true not only of lumbar extensors, this is true if you look at data on all muscle groups. And that's why it's very important that if you have older patients, that you also incorporate some type of progressive resistive or strengthening protocol for whatever you're doing, because you do get a lot of muscle loss, strength loss, endurance losses that could contribute to joint issues and different inability to perform ADLs. So I think this is a really powerful slide globally for physical therapists. Okay, so the normative data was done on 136 patients, and you think, oh, well, that's not a lot. Well, it was statistically significant, and that's all you need. So if you do 1,000 patients, 2,000 patients, you're still going to get the same results. You do have normative data. I actually worked on 2 projects with Dr. Jay Graves, super smart guy. He's the dean of a school now in Utah, University of Utah, exercise physiologist, really bright guy. But regardless, it's really nice to have some type of normative comparative data. And so you do have that on the lumbar machine. On the cervical machine, you don't have age groups, you just have males and females. And it's broken down into that. Okay, and then if you look at the MedX protocol, you're looking at doing 15 to 25 reps. And if you notice, that falls into the ACSM guidelines. And then as the weeks progress and you're adding more weight, sometimes it's going to go down and the patient's going to plateau. So they may go to 15 repetitions, 10 repetitions by week 5 to 12. Now, in reality, we hardly ever get to 12 weeks anymore. That was the original protocol, was a 12-week protocol. But just so you guys know, because a lot of therapists have asked me lately, why not work out 3 times a week on the MedX? Why not work out every day on the MedX? They did all that, guys, and they published it. So they work people out every day. They worked out people twice a day. They worked out people once every other day. And what they found is because you're isolating the spine, and think about it, it's just common sense. Again, this is just a machine. When you isolate and you do high intensity training on somebody, you do need a day of rest in between. And when you do have a clinical population, you may even want 2 days of rest in between, because the soreness that you get from high intensity training when you isolate a joint as isolated as you do on the MedX, you're going to have a lot of soreness. And also you could actually injure somebody if you keep adding more weight and you haven't had some time for it to modify that tissue or get the hypertrophy, get the muscle confusion, all the things metabolically that happen in the muscle for the muscle to hypertrophy. So the optimal is twice a week. Now, what do you do on that 3rd day? Well, on that 3rd day, focus more on functional training. You're not doing functional training while somebody's sitting on a machine, right? So look on your PRO and see, can the patient lift a 20-pound grocery bag? That's one of the things out of the oswestry. And maybe try having them lift the 20-pound bag. What's the best way to train that? And you're going to see your oswestry is going to go up and you're still going to be safe. Maybe don't start with 20 pounds, start with 10 pounds and go from there. But you see my point. On that 3rd day, you can do more education, go over the home program, do different things. You could do the back strong on that same day, although the back strong protocol is also twice a week. So on the back strong, we also found optimal was twice a week, not 3 or 4 times a week. You could use it as a warm-up, but the back strong is also designed to be progressor resistive as well. If we look at one of the first studies that was done, I was very fortunate to find this study. When I wrote our first grant in 1999, I wrote an NIH grant, and it happened to have MedX. I was ecstatic because I had no idea. At the time, there's only 3 randomized controlled trials in 1993 for low back pain. This was one of them, and it happened to use the MedX. And what you'll see is look at the control group and then look at the patients that were treated, and you're going to see a huge amount of improvement on strength. But the most interesting part, again, like I said, strength isn't that highly correlated with back pain, is that psychosocially they improved. And on these patients, they use the WIMPI, Wesiel Multidimensional Pain Inventory, which never had really good traction because I think the name was just stupid, right? WIMPI. And then they did the pain scale from 0 to 6. And that was very confusing for patients. You know, you go, well, what's your worst pain from 0 to 6? And the patient goes a 10. No, from 0 to 6. So anyways, but it did show that a lot of patients, their WIMPI scales improved, statistically significant. And not only did it improve in strength, but more importantly, got them back to ADLs and decrease their psychosocial issues. Okay, so this slide shows a big change. You're looking at 129% change. Sometimes we'll see 300% change. And all I want you to get out of this is that you can make huge changes when a muscle's atrophied and when you actually have like nothing in the tank. In other words, if you think about it, when you break your arm or your leg, when it comes out of a cast, you could hardly lift any weight. but you can get 200, 300, 400% strength gains once you start working out. And that's what you see. You see muscles were dormant, and all of a sudden you can get these huge changes. Okay, so what I would urge you guys to do this year is slow down. On the initial visit, you're going to do a comprehensive exam, look at directional preference, that's always important, and then address the patients and let them know about what's their recovery expectations. You know, I just told you earlier that a patient with low back pain, 90% recover within 3 months. I think it's very important to let them know that on the first day. That's evidence. That's evidence-based approach. Let them know, look, I know you're in severe back pain. That's unfortunate. I understand that, but you know, that's normal. That's why they call it back pain, not, you know, back fitness or back happy. It's back pain. So we're going to take that pain to our advantage. That's going to let us know things that we want to avoid right now for a short period of time. But today we're going to find things that are going to help you, and we're going to find those movements. Okay. Not only that, there's certain things that are safe. I'll show you in the clinic, and I want you to keep moving around at home. So we're going to use that pain for the advantage. But the good thing is that 90% of people get better within 3 months. You're here at the clinic, so we're going to try to even get you better quicker. From there, it's also important for you to make your visits, because if you don't, we know with back pain, 60% reoccurrence rate. So we also want to make sure you don't recur. From there, give them their home program on directional preference and really answer any questions, ask them any preferences that they have. What else can we do at home? Remember, I told you that these are chronic patients. So instead of doing the bird dog and things that they probably have done 10 different times in the clinic, see if you can get them on a walking program, something that we can progress their aerobic capacity. Aerobic capacity shows that you can perform a lot more ADLs. It helps with any condition, including carpal tunnel syndrome. And from there, get them into a walking program, jogging, cycling, aerobic, whatever you can get them into. And you're going to see that's going to improve their psychosocial aspect a lot better than if you're giving them some really low level exercises that they're beyond that right now. Okay. Just like you wouldn't give a patient with a knee injury a year later short arc quads if they've already, you know, they're doing 200 pounds on the leg press. So that's what I would do on the first visit and really go through their home program. On the second visit, get some information, get some PROs. Here I have the MTAP. I wouldn't use the MTAP unless it's a work-related issue. But do an oswestry and pick the questions out of the oswestry that they say they can't do. And if you think they could do them before, incorporate and fix your treatment plan. Make it more robust. Listen to the patient, put that in the plan and function. And you're going to see better results, better engagement. And then follow up and make sure you encourage them and you coach them to keep working through, because we know with back pain, whether or not you use MedX, whatever you want to use, if they go back to normal ADLs, typically their psychosocial and their pain levels improve. And so the patient's going to have a higher outcome. So from there, you're going to go twice a week for 4 weeks. And then typically you retest at every 4-week interval. And again, you're going to see the repetitions go back naturally. Now you can add weight from 5 to 10% on every visit, and you must. And that's another thing I see in the clinic. I see patients going up to the therapist saying, I don't want you to add more weight today. Can we use the same weight? And again, you really have to understand evidence-based, psychologically informed therapy doesn't mean that the patient tells you what to do. It means that you listen to the patient. So I would listen to them. I would be empathetic, but I would say, look, this is a progressive resisted protocol. So I must increase it. Last time you did 25 reps. I know you were sore. That's why you're a little bit hesitant, but it's safe to continue. Otherwise, I'm the first one that's not going to work you out today. And by the way, if we don't increase the weight, we're really wasting time. And, you know, not only do you want to feel better, do you want to get better? And this is what it takes. And I would explain to them, it's normal. This is what we're doing. The word normal is very important, unless it isn't and it's abnormal, and then you'd point that out. But I would highly encourage you to explain that. Also remember, the MedX is in foot-pounds for the lumbar machine. And depending on the angle, that could be less than 1/4 of a pound. So you could always, it'd be really unusual that if a patient did more than 15 reps, that you can't add a few extra foot-pounds on their next visit if they had 2 days rest. Okay, on the cervical machine, on the computerized, it's in inch-pounds. again, it's a very light torque measurement. Depending on the angle, it may be less than 1/4 of a pound or even less than that. So on inch pounds, you can again go 10 to 15% increases. And again, I would explain to the patient that you need to progress them because that's how the protocols were published. Now, if you're not going to work them out that day, if they have decreased range of motion, they had leg pain, they had other things, just like any other exercise, you're going to modify, or you're not going to do that exercise that day. Okay. But I would encourage you to keep strictly progressive resistive on the MedX and on the back strong. And everybody should understand that a foot pound is a pound, but it's a foot off the floor. It's a lighter torque measurement. Torque is measured by distance as well. So that's the MedX protocol. And then from there, I would get them into more functional things. On that third day and then at home, get them into function. Find out what's on your PRO. Listen to your patient. What do they enjoy to do as hobbies? How do we get them engaged? You know, if you get me fishing, I'll do anything. So, you know, that's my motivation to keep up my back workouts. Okay, I'll open up for questions if you guys have any questions. No questions? How about Garrett always has a question?
Well, let's see. How would you explain this to a person that's never seen the MedX before, and basically how would you simplify it for someone that doesn't really know what that is?
Yeah, just like we talked about before, that's a great question because it's very intimidating. It looks like a big machine and looks like a torture device. And again, I would tell them, look, it's a machine. It really helps to isolate the pelvis. I would demonstrate that when you bend forward and you go past your hips, your pelvis rotates, and now it's your glutes and your hamstring. What this machine does is we're going to really work out specifically your injured area. And, you know, working out your injured area usually has a lot better results. And this is something you have not done before. And so would you like to try something new? It's not easy, but there's an 80% success rate based on a study we published in 1999, Garrett, where 82% of our patients were better despite 6 previous clinical interventions, including surgery. So this is really worthwhile because I know you've been to 2 other PT places and you weren't better. And then you saw that crazy chiropractor that got you worse. I think his last name was Verna, right? And so this is going to be really worthwhile for you to try and see, would you like to try it? And so then you get the buy-in and then you encourage them and you educate, keep educating.
Yeah. That's awesome.
Monica, no questions?
Can you review like precautions and everything for the MedX, like in terms of post-surgical?
Sure. So just like any other exercise, you want to have stability. So globally, for a fusion, you're looking at 3 months to 6 months, okay? But that's going to depend on how many levels, the patient's age, and what the outcome of the surgery was. So I would double check when you're going to isolate and do any type of high intensity exercise on a fusion, not just, I would check and make sure that it's fused, have an x-ray and an okay from the doctor. Laminectomy, discectomy, you're looking at 4 weeks. Typically after 4 weeks, it's safe to work them out on the MedX. And anything else, red flag for exercise is the same. So any progressive progressive neurological deficits, any things that are contradictory to exercise, that would be the same.
So disectomy is 4 weeks?
4 weeks, depending on the outcome, typically 4 weeks.
Okay.
Discectomy, laminectomy, anything like that. Fusions, again, it depends on age. You know, you don't know what the bone density was or how old they are, how many levels. Obviously, a 1 level 22-year-old is going to be on there, I would imagine, in 3 months, 4 months max. Somebody had, you know, that is 68, 72, 75 with some opinion with 3, 4 level fusion, it may be 6 months to a year. Just get clearance from the doctor.
Okay, thank you.
Sure. That's a great question. Come on, somebody else has another one.
Hey, Dr. Verna. Hey,
Hi.
weird question on billing. Is a static test considered a performance test, or are we billing it as like TheraAct or TheraX?
Typically, you bill it out as a performance test, 97750.
Yep.
It has to go out with a printout. So when you bill out a 97750, Rick Katz can correct me if I'm wrong, you also have to send a report. So like if you do a MedX isometric test, you have to show the MedX report test.
Okay.
Or if you do an aerobic capacity test, you have to send out the report with that, okay?
Yeah. Looking at it in Raintree, because we typically do that under objective tests and it's pretty quick and easy, it's all set up. Is there a way we could add that to like our test observation area?
Sure, and I think we should do that with other performance tests. And what I would like for you guys to look at this stuff is more globally this year. Let's think smarter and work, not harder, but look at this as a performance test, just like any other. So we should add that to that field. So Hill, can you make a note of that? We can talk to Scott and see exactly how we could address this. But it would be really nice when you guys do that. I wouldn't do the MedX on the first visit. Typically, I would do it on the second or third visit, especially if it's a chronic patient and you know that there's no contraindications. It would be really nice if something would pop up and then you can pick that out. Just like, a Bjorn Sorensen test, a plank test, a step test, a one leg single hop, et cetera, et cetera.
Perfect. Thank you.
You're welcome.
All righty, so it is 1 o'clock, and so I just want to thank you so much, Dr. Verna, for this presentation. It was really informative and really helpful, and I appreciate it. And thank you for all of you for coming, bringing the questions, and this is what it's all about. And so it's just more learning, more growing, more education, and it's all for the patient. And so thank you guys so much. This will be going on to our Spine and Sport YouTube channel. So if you know anyone that missed this and they wanted to go back and look at it, you'll be able to look it up on Spine and Sport Physical Therapy on YouTube, and you'll be able to watch this very, very informative lunchroom. So like I said, thank you again, Dr. Verna, and I hope everyone has a really great rest of your afternoon.
You're welcome, and I want to thank all you guys for doing such a great job. Glad that you guys went through COVID, and glad that we still have focus on quality and making sure we help all our patients. And then this year too, we want to see how we can help our therapists to make things a bit easier in the clinics. So again, I want to thank you guys and have a great day.